Okay, so why are we here today? For me, today is very special, and even to the organization, because we focus mainly on education in the community. And we are looking forward to a point where we can have a healthy community. So not only out of concern for the health of the community today, but also in solidarity of those that have lost their lives and those who have lost loved ones during this pandemic. So we are having this meeting basically to just educate members of the community on the pandemic and also on another health condition that is prevalent within the community too, and that is prostate cancer. Challenges that our community members are facing and some of the barriers that are making people not to want to take the vaccine. While we are going on, at the bottom of your screen, where it says chat, if you have the opportunity, we are going to put a link there, only just because we want to be able to do a survey as we go along. And that survey will help us as a research for the community. It's going to be a data we're going to do for our community. So if you go there, you can just do a brief survey. So today we are here to just provide information. We're here to provide information that will enhance the confidence of community members, to reduce the hesitancy concerning the vaccine, and to also facilitate informed decision-making. So we have Dr. Sokolov, we have, who is going to address prostate cancer. We have Dr. Abraham, who will also speak to the vaccine, even Dr. Fina. And after this conversation, we are hoping that people will have some level of confidence in the vaccine and be able to make a decision that will benefit them, their family members, their friends. So how did we get here? And why, why is CHIN involved in this? CHIN is a nonprofit organization that was started in 2018. And the goal of CHIN is to empower the community through health education. For we believe that education, knowledge is power. So if we provide you the education, you're more apt to making a better and informed decision concerning your health, concerning the health of the family. And CHIN focuses on four pillars, and our pillars are education, which is why we are having this meeting today, to educate the community. We do training. We also serve as an advocate in the community. And moreover, we want to be a resource for the community. That is, community members can depend on us for information when they need it. They can come to us if they need direction, especially when it focuses on their health. Today, we are going to call on Dr. Fina. I'm not sure if she's already on. Dr. Fina will be able to introduce our political leaders who are on before she go into her own conversation. But before I exit, I just wanted to say that you can also follow CHIN on Facebook, and you can check us up on our website, and there will be more information as we go along. Since I'm the host, I will intermittently be talking about Community Health Awareness Network. So you can check us up at www.chinglobal.org if you need any more information concerning the organization. So not to waste any more time, I'm just going to bring on, once again, welcome to all of you who are just joining. And I'm going to have Dr. Fina, who is going to come on. She is the president and the CEO of AdMeTech, who is in fact our partner. And she's going to introduce our leaders and also just follow through with the event. So Dr. Fina, if you are on, if you can unmute yourself and just go right into the conversation. Dr. Fina, are you on? Okay, I'm just gonna move forward because I guess she's probably will get on. But before, she was gonna introduce our Senator, Senator Moore. He's already on. So I'm just gonna, by way of introduction, invite our own Senator Moore of Worcester County onto the floor so he can say, welcome, Senator Moore. You can unmute your mic.
Okay, I think I'm unmuted. Can you hear me?
Yeah, we can hear you. Go right on.
Okay, thank you. Thank you for inviting me today, and good afternoon to everyone, and welcome to the conversation, COVID and prostate cancer. We have a panel filled with wonderful and knowledgeable people here today who are going to be answering a variety of questions and addressing a number of issues. The issues at hand are the current state of the pandemic in the Worcester area, what you can do to protect yourself and your family, and how can you deal with your prostate health in the midst of a pandemic, and what new innovations are there in prostate cancer treatment. I know that something else we will be talking about is hesitancy when it comes to receiving the COVID-19 vaccine, whether it be the Moderna, Pfizer, Johnson & Johnson vaccine. I would just like to emphasize how important it is to get the vaccine. Whenever it becomes available to you, it not only protects yourself, but also your loved ones and anyone else that you come into contact with. We all want to return to our normal lives, as we have been dealing with this pandemic for quite some time, and receiving the vaccine is imperative to allowing us to do this. During this discussion, we will hear from our incredible panelists and have everyone split into breakout rooms to discuss the issues at hand, followed up by a Q&A session at the end. I look forward to hearing from our panelists, and I thank you all for bearing with me in my opening remarks, but I think it's time for us to get started. Thank you all again for attending, and hopefully you will enjoy this.
Thank you, Senator Moore. I do appreciate you being a part of this event, and thank you for the work, for encouraging your people. Going on next, I'm going to ask Representative LaBeouf, who is also representing Worcester, to just jump in and say a few words.
Great. And again, thank you, Lovo, and thank you for everyone for being here and taking this valuable time to talk about some really important topics that are impacting our community. I know lots of times there is there's been a lot of rumors, there's been a lot of hesitancy, there's been a lot of misinformation that's been going on in the news regarding the safety of the vaccine, regarding the efficiency and how it interacts with different medical conditions. And it's great to have a community-based organization that can really meet people where they are and can really spread the facts and answer the questions that sometimes the medical system might not necessarily have the proper information to answer, or individuals might not feel comfortable to answer those particular questions. Definitely, I want to emphasize what my previous legislative colleague said about the vaccine. I did get my vaccine. I actually got my second dose of the Pfizer on Thursday, and it's brought a world of relief to me, knowing that I'll be able to continue to do my position and interact with my community, knowing that I'm putting people, keeping people in safe. And especially as things are opening up, and especially as we're starting to remove some outdoor mask mandates and starting to look at our businesses, it's important that we don't see another spread. As we've seen in some other countries where they've had to go to a second lockdown, and that's because proper procedures weren't followed and because there really wasn't the discussion about how to make sure that people are still handling themselves after the vaccine, still wearing masks, and still taking safety protocols. And definitely talking about prostate cancer. That's an issue that it's not the most common medical condition that's spoken about, but it really disproportionately impacts the Black community, and in particular, the African immigrant community. And so really looking forward to learning more about this and how myself and my legislative colleagues can be allies in this continued fight. So thank you, and looking forward to sharing this time with you this Sunday.
Thank you, Representative LaBeouf. Thank you for taking the time to also be with us. I'm going to introduce Rufina Keta, she had the opportunity of speaking with or having an interview with Dr. Maddie Castile, who cannot be here today because of prior engagement. So she had the opportunity to interview her, and we're just going to play that short video very quickly. So Rufina.
So hello, everybody. Thank you all for joining today. This webinar, this is our first Zoom event, and we're super excited to have all of you here. I just want to introduce Dr. Maddie Castile. I had the opportunity of speaking to her, and she was able to give us some brief information about the COVID crisis here in Worcester, Massachusetts, but also the health equity vaccine clinics that's been set up all across Worcester. So I'm going to be playing this video for you. As I said, it's a short interview with Dr. Maddie Castile. So you guys just bear with me one moment and I'll be playing that video. Thank you.
Here at least, and not necessarily with you when you're doing it virtually, but thank you for asking me. If you can go to the next slide. So I just want to tell you a little bit of background data, just so you know what's happening in Worcester. So Latinos make up 22% of Worcester's population, and they're 33% of all COVID cases, which are shown on the slide by the orange bar there. And the Black or African American population make up 13% of the city and 15% of all COVID cases. And you can see that by the light blue bar. And you can see the white population make up 37% of the cases. So the majority of cases are both the Latinx and the Black or African American community. Next slide. And then who does it affect? It truly is affecting younger age people, and you can see that the orange at the bottom is also Latinos, and 37% of Latinos are of the age of 30 to 59. The light blue again is Black or African American, and also it's affecting the youth. So you see that 46% of all youth cases are Latino, aged 0 to 17. And then they've progressively increased. Black or African Americans are still, you can see the percentage in the light blue and the percentage in the white and the darker blue. Next slide. And so when we look at ages and who's being hospitalized, we can see that the average age of the white community is 69 years old, and yet when we're looking at the Black community or the Latino community, you can see that the average age for the Latino community is 55, so much younger, and for the Black community is 56 years old. So people are affected at a much younger age, and partly because we're front-facing people, live in multi-generational households, and so and don't have the ability to isolate, and so therefore much younger people are being affected. Next slide. So when we look at what's happening in the different communities, we know that for COVID, 10.4% of the city's total population has had COVID, and the Asian community, 6.5% of the Asian community has had COVID, 6.9% of the white community has had COVID, and 11.5% of the Black community has had COVID, and Latino, 15.8% of the community has had COVID. So the two highest are Black and Latino communities with the highest numbers of COVID. So next slide. And then this is just sort of showing you social vulnerability. The areas in the darker, the first slide to your left there, shows the different neighborhoods, Great Brook Valley, Bell Hill, all the different neighborhoods that are being affected. Those are the highest of the darker the color, the higher the positivity neighborhoods. And you can see that when we look at social vulnerability, which means what's their socioeconomic, what's their household composition and disability, minority status, language, or housing type and transportation, that again, it falls into the same neighborhood as we're seeing the positivity rate. So when you overlap all of these things, the same neighborhoods are being affected. So next slide. And again, you're looking at a slide here, and the one I'm going to really talk about is who's being vaccinated, and the blues, in particular the dark blues, are the highest are the ones who are being highest vaccinated, and that's mostly the west side of Worcester, which is more affluent. And if you look at the lighter pink or orange, that's actually the neighborhoods that we just mentioned before that have the highest social vulnerability index. So next slide. And I just wanted to show you what we've been doing is actually prior to even vaccinations or to testing, we've been really looking at communities of color and trying to figure out, because we know that inequities exist in communities of color. And so how do we start working through this process? So before we even had equity vaccine, we went out to the different areas, the shelters, the housing authorities, and then subsequently we ended up getting from the state what they call equity vaccines. 20 cities in Massachusetts who had the highest rates of COVID for communities of color are the ones who received the equity vaccines. So we went to different areas, we went to churches, any faith-based organizations, really, we went there to vaccinate. Any place that people felt comfortable, was it the YMCA, the YWCA, areas where people tended to frequent, those are the areas that we went to. We also went to businesses that we knew our community was working in, and so we went there to vaccinate a lot of the people. Next slide. And this is just telling you the amount of vaccines that we've given. We've given 10,459 vaccines for a total of 7,177 individuals. Next slide. And then this is just the numbers of the state doing their vaccination, the first block there. And you could see that the majority of people who got the vaccination from the state were white, and less for Black and less for Latinos. As we went on through our different sites that we went to, you can see the number of Latinos and Blacks who were vaccinated increased. And overall now, when we look at our data, we know that of all the vaccines that we've given to date, 75% of those vaccines have gone to communities of color. So next slide. And this is just the state numbers, which show that communities of color make up 21% of the total vaccine doses administered in comparison to 71% of doses that have been administered to white individuals. So the purple is white individuals, and that's at the bottom, and you can see that 71% of those were to the white community, and the other colors, the orange, the blue, and the green, are communities of color. Next slide. And so it is the most efficient way to really give access, I should say, to communities of color, is to go where they are, and that's what we've been doing. So if you have any questions or you want to get anybody vaccinated, here's my email address, castilem@worcesterma.gov. And we'll be glad to get people into our clinics. They are all open clinics, so we look forward to having you. And again, these are clinics that are for communities of color, so that we can increase the access to people who have not been vaccinated. So thank you.
Thank you so much, Dr. Castillo. We'll just keep this up so people can take this information down if needed. We just have a few questions for you. The first one being, we know about the J&J vaccine and the controversy around that. Can you talk a little bit more about how that has impacted our community? And not only that, what vaccines are you guys giving now?
So, Rufina, I think that we knew that coming around in May that the hesitancy would start to happen. During this whole time, we've had people really wanting to get vaccinated, and now we've reached that ceiling in a way. I think a lot of it was also from Johnson & Johnson and what happened with Johnson & Johnson. And actually, in communities of color, Johnson & Johnson was a preferred vaccine because it's a trade name that they know and have been comfortable with. And so we certainly feel comfortable giving the Johnson & Johnson vaccine, and certainly if there's any questions about it, then we could say that 55 and above, women, we shouldn't give it to, and men we're perfectly fine giving it to them also. And so I think that when we go out now, while we take either Moderna or Pfizer, and we take Johnson & Johnson to offer that to people, because it is easy. It's a one shot. Some people don't want the 2 shots, so it's a good option to have for people. But certainly, it has increased the hesitancy of people since we had those blood clots.
Thank you for that. Another question that I have is, within the African immigrant community, church is a big thing, and I know a lot of churches have started to build health organizations within them, health departments. So are you guys willing to work with these health departments to maybe on a Sunday run a clinic in the actual church?
Absolutely, and we've been doing that already. We have been going to some of the African churches to do vaccinations, so certainly we would love that. We can certainly do that, and we can certainly also, if you know of anybody who needs a vaccination, please contact me. We'll forward their names so that they can be called and they can give the options of what vaccines or where we're going to be so that they can get vaccinated at their convenience. But certainly would love to go anywhere where we can vaccinate people. So we would appreciate that.
Great. And the last question, Dr. Castillo, is now that we have the vaccines out, are there new COVID-19 guidelines that we should be following?
I think now what we're looking for is really the 85% herd immunity, that everybody gets vaccinated. That's our main goal. As of today, if you're outside, you're able to take your mask off while you're outside. So those are things that are moving in the direction that we want to go. I know that our capacity has increased somewhat. The governor just gave his recommendations, and I'm actually going to review those recommendations, but it's opening up more and more as the time increases.
Awesome. Dr. Castillo, thank you so much for being here with us and sharing this. We appreciate your time and your effort through, providing equity for our community. Thank you so much.
Thank you. It was a pleasure. Thank you. Thank you all.
So thank you guys for watching that brief video with Dr. Castillo. One thing I would like to mention is the questionnaire that we have developed. We'll be placing the link in the chat. Chan right now is trying to develop data for the African immigrant community. So when you get the chance, just switch on to the chat, click it, and then just take the quick survey. It's only a few questions. Thank you guys again for being on.
So thank you, Rufina. And even though Dr. Castillo is not here, we also want to say thank you. And we do want to welcome everyone else, because we know that people who are on are not just only from Worcester. So from around Massachusetts, and if possible, from around the United States, we want to say thank you for joining in. It is a great pleasure to have you on. So Dr. Fina is she's on now. So I'm just going to go backwards and see that I can welcome her to just say a few words. She is, like I said before, the president and CEO of Agnetaq. She is our partner, and which is why we are having this event today as we move forward with our prostate cancer campaign. So Dr. Fina, if you will please unmute yourself, we appreciate it if you can just come on.
First of all, my apologies that I joined the event a few minutes late. Something urgent came up, but I am here right now, and I would like to thank Lova and Rufino for organizing this event and inviting me to take part. Our event today is a part of the AdMeTech Foundation statewide program in prostate cancer awareness and education. For over a decade, our program has been addressing health disparities in prostate cancer. Black men are 2.5 times more likely to die of this disease compared to white men. Worcester has some of the highest death rates and disparities in Black men in our state. And we are pleased to partner with Chen and University of Massachusetts to change that. These health disparities are related, and related loss of lives are unacceptable, particularly because prostate cancer is curable when detected early. In April last year, early in the pandemic, we have recognized that the areas of prostate health disparities, including Worcester, directly overlap with the pandemic hotspots. Both COVID-19 and prostate cancer have emerged as leading health disparities. Since last May, we have expanded our program to include education about prevention, diagnosis, and treatment of both prostate cancer and COVID-19, as reflected in this event. Prevention and early detection are critical for improving patient care for everyone and eliminating disparities in prostate cancer and COVID-19. Vaccines are the best and most effective tool we have today for preventing COVID and ending this pandemic. COVID vaccines have been proven safe and effective, as mentioned, in millions of people. Complications are extremely rare, and vaccines prevented infections, severe disease, hospitalization, and death already in countless people. As President Biden recently pointed out, vaccines are the best way to protect not only ourselves, but also our families, our communities, and everyone we care about. By accepting vaccinations, every individual helps us get one step closer to ending this pandemic and being able to see our parents, children, grandchildren, friends, and co-workers safely. If someone gets sick with COVID and develops flu-like symptoms, it is critical that we isolate ourselves to protect people around us and contact our doctor right away. Early detection ensures the best treatment and saves lives. Dr. Castell already addressed COVID-19, and Dr. Abraham will address COVID pandemic in a few minutes and the importance of vaccinations further. In prostate cancer, screening with blood test called PSA is the best tool we have for prevention and early detection. With early detection of prostate cancer, every man is alive in 5 years. With late diagnosis, when distant cancer spread is present to bones and other parts of the body, only about 28 men out of 100 men are alive in the same period of time. It means that with late diagnosis, we lose 72% of men in 5 years. Dr. Sokolov will address the latest advances in prostate cancer care. I would like to complete my brief remarks by expressing my deep gratitude not only to leaders of CHEN, but also to Worcester delegation, to representatives, to members of the Worcester delegation to the Massachusetts State House, who have been strong supporters of the AdMeTech Foundation program, which made this event possible and are present today. Senator Michael Moore and Representative David LaBeouf. Thank you so much for your attention.
Thank you, Dr. Fina. We're gonna just move right along, and just a quick reminder for individuals to go into the chat and be able to do a brief survey. So I'm gonna invite Pastor McCall, who is gonna introduce Dr. Abraham. So Pastor McCall, if you're around, please unmute yourself.
Thank you very much, Lovo, and I'd like to say thanks for the invite. Thanks for organizing this program. Let me quickly get to our introduction. I'd like to introduce to the panel Dr. George Abraham, who serves as the Chief of Medicine at St. Vincent Hospital in Worcester. Dr. Abraham is a professor of medicine at the University of Massachusetts Medical School. He is an adjunct professor of medicine, adjunct professor at the Mass College of Pharmacy and Health Sciences. Dr. Abraham is a board certified physician in internal medicine and infectious diseases. He serves as the chairperson of infectious diseases at the American Board of Internal Medicine. Dr. Abraham recently became president of the American College of Physicians for the year 2021 to 2022. In addition to his many roles, Dr. Abraham serves as the chair of the Board of Registration of Licensing in Medicine in Massachusetts. He has received several awards, including the AOA Volunteer Faculty Award and the Outstanding Primary Care Educator Award of the UMass Medical School. Most recently, he was awarded the John H. Clark Leadership Award by the Federation of State Medical Boards. Dr. Abraham has authored many publications, well over 100, He has authored abstracts and other book chapters, and he's an invited speaker at national and international meetings. I've also had the opportunity to sit on a panel with Dr. Abraham. Dr. Abraham is going to speak to us today on the recent advances in COVID-19 care. He's also going to talk about the efficacy and importance of vaccinations. So I'd like to invite Dr. Abraham to take it from here. Dr. Abraham.
Thank you, Moses, for that kind introduction. Bear with me 1 second while I just get my screen lined up. Thank you very much, Moses, as someone who I've worked with before, as also Lovo, for their advocacy and work on the work of Liberia in general and their needs in Liberia, as well as the Liberian community here. And I'm really honored to be part of this conversation this evening. The subject of COVID is vast and it's not possible to cover everything. So what I've done is just chosen some select slides just to address different topics, and then hopefully the question and answer session in the chat or otherwise would serve as being a more meaningful way of addressing questions that you might specifically have. The treatment of COVID continues to be a challenge. We do not have effective treatments of SARS-CoV-2 infection as we speak. And so there is significant loss of life as well as complications associated. Given that we are about almost 18 months into the illness as we have recognized it, we are now looking with interest at something called long COVID or long hauler COVID, which means people who have had illness and then go on to develop complications which persist for months, maybe longer. So we know that at least 6 months or more, some people may have residual symptoms after they've had infection that addresses several different organ systems, most commonly the lungs, but definitely other organ systems are known. The heart is well known to be involved. It causes an inflammation of the heart called a myocarditis, which can lead to heart failure, causes this generalized fatigue, which a number of people complain of still, that tiredness persists for weeks to months after their illness is over. The breathing difficulty is common. Those of you who follow the NBA, you will know that the Boston Celtics player Jason Tatum, who had COVID-19, still complains of mild shortness of breath, and he's not back to his original self because he's concerned that some of this is related to his having had COVID. Similarly, affects a number of different diseases, and don't forget the emotional or psychiatric illnesses. So the emotional well-being, which has been affected by either loss of life or family members, or even by the illness and the disability that has followed, the isolation that has followed, so on. So there are a number of different factors. So therefore, what does that suggest? We need to be able to say that we want to avoid illness if we can. We don't want to get disease. What is also interesting to know, this is data from the CDC, that in different age groups, you see where in the last 1 year, coronavirus has really taken over as a major cause of death. So it's in the top 5 causes of death from the ages of 18 to 49, all the way to the ages of 70 to 80 and above. And as you can imagine, the older the person, the more likely that they will be facing a life-threatening situation. So this is extremely worrisome by the fact that an acute viral illness can cause this degree of complications and death. There are many variants or variations to the virus around the world and even in the United States. And so we've heard a lot about the term variant. So what we originally inherited in the US was a variant from the original virus in China. So from that variation, we have now hit another variant, also called the UK variant, or the B117. That's the commonest variant right now in the United States. So which means over 30% of virus here is the B117 variant. And I'll show you a scale of relatively what is more worrisome and what is less worrisome. We have also seen the Brazilian variant here in Massachusetts specifically because we have a big Portuguese population in the Fall River area. So Fall River, Cape Cod, etc. We were the #1 state till recently. Florida has taken over from us. So we are number 2 in the country in terms of the number of Brazilian variants. It's called the Brazilian variant because it was first identified in Brazil. And as you're aware, Brazil is going through a major epidemic. And there are areas of Brazil, particularly Manaus, the northern part of Brazil, which is the Amazon Valley, has been decimated by this Brazilian variant because unfortunately there is both a shortage of vaccine as well as the fact that some of the vaccines that they have been able to acquire, which is primarily the Chinese vaccine, is not as effective against this variant. There is also another variant called the South African variant, or the 1351 as it's called, and this is probably the most worrisome of all the variants, and I'll show you that in a moment. But this variant was primarily identified in South Africa. It has been identified here in the US, but it's very low activity as yet, which is fortunate. And so therefore, this is another variant which we are watching very closely. Most recently, you may be aware that India has become the hottest country in the world with the maximum number of COVID-19 exceeding 400,000 new infections every day, and that's believed to be an underestimate. So there is another variant called the Indian variant, which is actually a double mutation, not the single. So what the mutations imply is the surface proteins of the virus undergo change and some of the proteins disappear. And the vaccine that is used searches for certain amounts of proteins, and it has to fit like a lock and a key. So the key fitting into the lock, the teeth of the key have to match with the grooves in the lock, and that's when they lock on, and that's when the vaccine works against the virus. So if that conformation in the lock changes, then the key no longer fits, so which means the vaccine won't work as well. And that's the challenge with the variant. So that's a simple-minded way of looking at it. So the Indian variant is the most recent one. There are many others along the way, but this is one which we are also watching closely because it is rapidly expanding. First identified in California and now spreading through many other parts of the United States itself. So as we know in the US that Michigan was one of the hottest spots. The numbers in Michigan are coming down gradually. The numbers in New York and New Jersey, which were the other 2 hotspots with the 3rd surge most recently, have nicely come down or are coming down well. And so therefore we are less worried about that in the US. So as the vaccine increases, we will be able to decrease the surge in cases. What we are more concerned is worldwide, how India has rapidly taken off so much that they are now exceeding the daily numbers than even what we in the US had when we were at the peak of our epidemic. And so therefore that's the country we are watching right now. This was in India where about 6% of people, it's estimated, who actually require hospitalization, and about 94% of the epidemic could be managed at home. But people have gone into a panic. Everybody wants to be in hospital. Everybody wants to be on oxygen, whether they require it or not, because they've developed the psychological fear that they're going to die if they don't. And so that has led to hospitals being overwhelmed. The healthcare system is really crumbling under the pressure of sheer numbers. It's a country with 1.3 billion people, the 2nd largest country in the world after China. And so therefore this was developed from here in the US to really educate people about what they can do to handle the epidemic and not everybody go in a hospital where if they don't have COVID, they are highly likely to get it just because the hospital just cannot control the number of people that are walking through the institution. So this is a critical one to look at. So to understand all the different variants that we know of on a scale of what is most worrisome and what is least worrisome. So the D614G, as I mentioned, was the original variant virus. This is a variation of the original Wuhan or Chinese virus. And this was what was identified in the United States in March of 2020. By September 2020, this was the predominant strain all over the country till we got hit by the UK virus. And thereafter, there was a California variant. Recall a couple of months ago when California was at breaking point with the number of different viruses, variations and the number of cases. The India variant looks very similar to these, but in a scale of lethality, the most worrisome is the South African variant, which fortunately, is the least prevalent in the US right now. This is why there is so much pressure to get vaccine out, because the more we are protected, the less likely we will get infected, the less likely that these variants will go on surviving. So variants to a virus occurs not unique to COVID, but every viral illness. Every year we grapple with variations to the flu virus. So the flu virus changes, which is why our vaccine is never 100% match with the flu virus, because it keeps changing. All viruses keep changing their outer surface to avoid being detected and to avoid being killed. That's nature's way of protecting itself. And unfortunately, so the only way to protect that is by cutting off new infections, which is getting vaccine. So Brazil is less so. There was a New York variant because when there was a surge in New York, but essentially the most worrisome is the South African. All our current vaccines work against all these variants. It's probably least effective against the South African, but even then, well more than what we would need to acquire immunity. So the short answer to the question is vaccines work. And this is a summary table which just compares across the board all the different variants, the countries where they've been identified, what types of mutations there are. I would not focus on what the specific mutations are. That's beyond your interest, but it's basically for us to understand. But it causes what's called immune evasion, which means it evades, it hides against the vaccine or ways to kill it. And so the efficacy. So the efficacy essentially is that at least for now, all the vaccines available in the United States works against all of these variants, some much more than others, but the bottom line is vaccines do work. And this is a comparative table to give you an idea of exactly what I'm talking about. So we said flu vaccine was our general gold standard, which we used for a vaccine efficacy, and flu vaccine hovers around 40% success rate every year. The WHO said at least if a vaccine is 50% successful, that means half the people who get it are able to successfully avoid getting COVID-19 infection, then we will say our vaccine is successful. So that was set as the threshold. So the threshold for the vaccine, if you look at it, only two vaccines, the Novavax, which is not available in the United States, it's not been licensed or not available even for trials, so we would forget about that, and the Chinese vaccine, which is just about at the 50% mark, just slightly to the right of 50%. But all the other vaccines that are available are way more effective and way, way more in terms of the efficacy of numbers. So what this is telling us is our vaccines work against all the different variants. We need to get vaccine as the only way to protect ourselves. And if this does not convince us, then probably nothing will convince us that we need to protect ourselves. This is the only effective prevention. So a lot of questions have been raised earlier in the conversation with Dr. Castile. The same question was raised. What about the story of blood clots? And this is just a timeline to show you when the vaccine was approved. And then ultimately we started vaccination. We get these 6 cases of where the platelet counts dropped and the clotting factor was identified. People had either a stroke, some people had just clots elsewhere in the body. One person actually died. And then the CDC put a pause, studied it more, and then reactivated or started it all over again. So the concern, everybody focused on this, oh my goodness, there are clots associated with this, so therefore this vaccine is unsafe. Therefore, all vaccines must be unsafe. So therefore, I don't want to take a vaccine. And so this I liked as a nice slide because it puts in perspective. So the chance of getting a blood clot from the Johnson & Johnson vaccine was about 1 in 1.2 million. That's the same odds of you getting hit by lightning in a year. And if you were to put it in perspective of many other illnesses, so we get into a car accident and we could be killed from an accident or an injury, from dying from COVID, we are 23 times more likely to die from COVID than we are to get a blood clot, or to get some serious complication from the vaccine 11 times more. So the point being that the odds of complications from getting the actual illness or even from being hit by a car or some other accident far more than the risk of a blood clot. So this is why the CDC recommended that the vaccine be reintroduced and people get the vaccine. The biggest advantage of this vaccine is it's room temperature. It doesn't require special storage. It gives only a single dose, and it gives you equal efficacy 4 weeks after the full efficacy is. The partial efficacy starts at 2 weeks. The full effectiveness starts at 4 weeks after the illness, and the risk of complications are exceedingly low. Another common question asked is about pregnancy and the fact that should a pregnant mother or someone who is intending or planning a pregnancy, should they get the vaccine? And so this is the American College of Obstetrics and Gynecology. Initially, they were on the fence. Now they have come out and strongly recommended that every person should safely get the vaccine. At least 30,000 women have gotten the vaccine and have had a safe pregnancy with no complications. And therefore, there is no rationale today to avoid getting the vaccine, to wait till after pregnancy, or to be worried that this will interfere with pregnancy. Neither happens. The risk of getting COVID-19 in pregnancy is far greater and more serious than getting a vaccine in pregnancy. So the biggest bottom line is that apart from the fact that vaccine protects the person who gets it, the other piece is that we also reduce the risk of transmitting the vaccine. So there are multiple benefits. Number one, there are 0 people who have died from COVID-19 after getting the vaccine, which means there are 0 risk of true deaths, at least none documented so far, from serious illness causing death directly due to COVID-19 in somebody who has been fully vaccinated, number one. Number two, serious hospitalization, 94% reduction. So virtually extremely small, 6 out of 100 times that they would actually even get into a hospital with a significant illness. People may get mild or moderate illness, but they also are very low transmitters of the illness, which means they are not infectious to others the same way as someone who has not been vaccinated. And so therefore, neither do they acquire illness, nor do they give illness to somebody else. That's the huge benefit in addition to the personal protection. That is why the vaccine is so useful. So last word, the CDC talks about masking, and recall the CDC has changed its recommendations of masking. It no longer recommends a single mask, but to use double masking if it is if someone who has not been vaccinated and is still waiting to get vaccinated. Recall, there is nothing holding us back now from getting vaccine. It's just a question of signing up and waiting our turn to get that appointment to get vaccinated. So the combination is a cloth mask and a surgical mask, or the blue loop mask as we call it. If we wear the two, the cloth mask on the outside and the surgical mask on the inside. When we wear that colored surgical mask, the colored surface is always on the outside and the white is facing the inside, which means it's in contact with our nose and mouth. The reason is that white layer is an absorbent layer, which will absorb the moisture from our breath as well as our saliva when we talk, so that it doesn't spread outside the mask. The blue is a more non-absorbent layer to prevent anything coming through. The combination of the cloth on top of the mask, called double masking, increases the risk, increases the protection to 95%, about as good as the healthcare personnel who use an N95 mask. The other piece that's done is, if you're not able to use a double mask, the CDC recommends to loop and tie, which means you tie these two ends together to form a knot right at the junction here, and then wear it. So what happens is it creates a good seal all around. And so therefore prevents air from leaking from the side of the mask or under the mask into our nose and mouth. So either a tie or a double mask is what's recommended for non-vaccinated people. For vaccinated people, a single mask is still more than adequate to protect oneself. Someone asked about what the newest guidelines are from the CDC. So this is in a simple graphic form what it is. If we are outdoors, so out in the open, then because the air is constantly moving, it will move the virus away from us, and so we don't need to worry about virus hanging around. So if we are outside and we are more than 6 feet apart, so we are able to distance, no mask. If we are outside and not able to distance, which means a crowded place where people are close to each other, etc., we should wear a mask. And if we are indoors, we are inside, whether we are able to distance or not, we still will wear a mask. So that's the simple-minded way of looking at it and to think about it, even if we are vaccinated, to keep ourselves maximally protected. I will stop here, and I'm happy to take questions now or later. I'll turn it back to Lovo and Rufina to decide how they would like to proceed.
Thank you, Dr. Abraham. So we are going to do the question section later at the end. We're going to jump right into, I'm going to jump right into introducing Dr. Sokolov. So Dr. Sokolov, very briefly, is the professor and chair of urology at the University of Massachusetts School of Medicine and UMass Memorial Medical Center. And Dr. Sokolov is also on the board of AdMeTech. He has been with Chin through almost all of our prostate cancer event. And today I'm very happy to call on him again to speak to the people, speak to all of you who are on this meeting right now concerning prostate cancer. So Dr. Sokolov, if you will please turn on your mic or unmute yourself, and welcome to the floor.
Sounds good, Lovo. Thank you. Hopefully you can hear me okay. I'm having connectivity problem with my my regular computer, so no slides, just going to speak a little bit because I'm on my laptop and I didn't save anything on it. Really a pleasure to be here today, and in fact, it's always a pleasure to partake in any event from either CHAN or AdMeTech, two groups I've been involved with. Well, AdMeTech since I got here 7 years ago, and CHAN, I think I did my original talk for you guys about 2 or 3 years ago. It's always just a blast. As Lovo said, I'm the chair of urology at UMass Medical School and UMass Memorial. I have a 25-year career post-training specialized in urologic cancers, principally prostate cancer. Now, I was given a very large and broad topic to discuss today, topics and updates in prostate cancer, but because of the extent of the subject, I'm really going to limit comments to those I feel are most pertinent to today's webinar, especially in relation to some of the COVID issues. As has been mentioned, men of African descent are at the highest risk for developing prostate cancer. Worcester's ground zero. We have such a high proportion of men from Africa or of African ethnicity. One of the biggest issues that strikes us, and this is something Dr. Stern said and Lovo said, is that awareness and access. Getting men of African ancestry, whether African American, Afro-Caribbean, African expatriates, these have the highest rates of prostate cancer in the United States. Within Massachusetts, the incidence and death rate from prostate cancer in Blacks and men of color is highest in Worcester when compared to all the other counties in the Commonwealth. Unfortunately, as we all know, there are these numerous social and political determinants of health which lead to the health disparities, which further impacts access to getting health care for these Black men. This has been dramatically intensified over the last year or so, given that COVID has really impeded people from seeing their primary care physicians. There's a lot of data out there that just in that last year and change, there's been a decrease in health screening for a variety, colonoscopies, mammography, diabetes, but primarily prostate cancer screening being one of them. And as Dr. Stern conveyed in her earlier thoughts, that PSA blood test is an important tool to diagnose prostate cancer. And unfortunately, over the last year and a half, the rates of screening have decreased. Therefore, I would say the most crucial thing we can do is spread the word that the doctor's offices are safe, we're open, and it's really more dangerous to delay prostate cancer screening than coming into our clinics or our offices for screening. For those who've postponed seeing a urologist or getting a PSA blood test, call us at UMass Urology, call your primary care physician as early as tomorrow. Like I said, we're all open, we're all safe, and we can see these. Now, with regards to all of the many new developments in prostate cancer, and believe me, every day I get updated on something new, I'm really proud that of the ones I'm going to mention, that the UMass Department of Urology really is leading the state in many of the improvements we're seeing. So if I were to sort of stratify prostate cancer into the screening and diagnosis part, the treatment modality, treatment for early, treatment for late, we'll start with that screening and diagnosis. We need that PSA blood test, that finger exam, the digital exam, and if either one is abnormal, we need to do a biopsy to make a diagnosis. Advances that have really taken off in the last few years, combining MR imaging, magnetic resonance imaging, with ultrasound to do the biopsies. We've now done over 1,500, almost 2,000 biopsies combining the two, making it a much more accurate procedure. Decreasing the need for repeat biopsies down the road, and really be more accurate. In addition, on that biopsy side, there's now a movement, and we again are part of that, of transitioning from a traditional transrectal approach where the probe is put in the rectum to one that's called transperineal, where we go through the skin. It's easier on the patient, less risks of infection. Some people feel it might even be more accurate. And these are all advances that we're doing locally. Nationally, there's a trend towards it, but we're sort of leading the charge. And these are new developments that are available right here in our own backyard. Moving on more towards the treatment side, if a man is diagnosed with prostate cancer, many times treatment is necessary using either surgery or radiation as a treatment modality. And one real major improvement in the last year has been something called Retsu-sparing prostatectomy. Fancy name, still the robotic prostate surgery that we've done for the last 15 years, but certain improvements in it where the urinary side effects are diminished considerably. It's a dramatic improvement. It's available at select places like ours, but it makes that side effect from treatment less, making it more normal lifestyle when one has treatment like surgery and during that recovery. Lastly, just there are men, unfortunately, who develop metastases or spread. And over the past year or two, there have been a host of new medications, new drugs that have been developed and made available to our patients. In the old days, we would use a modality of just knocking down male sex hormone testosterone, which can effectively decrease further spread and growth for a period of time, but a lot of side effects. Now we have very specific targeted therapies that either boost the immune system or interfere with various pathways within a cell that it needs to replicate and reproduce. And again, the side effects for the patients undergoing this, the overall survivability, all increased tremendously because of these. While all of these advancements do improve survival and they do decrease the side effects for the men undergoing prostate cancer, I can't emphasize enough that it all starts with screening. Men need to get the PSA blood test, need to get the digital rectal exam, and they need to meet with a urologist specialized in prostate cancer if either one of these is abnormal. And it's that initial step of getting men to see the doctors, to get the PSA blood test that groups like CHAN, AdMeTech, my own institution of UMass, where we're trying to improve as much as possible that awareness and access and making the most impact in our community so that the Black men with that highest risk of prostate cancer can get the care that they need. And I think that's pretty much my time limit. So I'm going to stop with those comments, but obviously here for questions and answers, and I can fill in anything that Lovo or Dr. Stern or Dr. Abraham, if anyone wants to add, I'm glad to fill in from there.
Thank you, Dr. Sokolov. And before we go into our Q&A, I just want to remind everyone that we still have information in the chat, and there's a link. We are still doing the survey. If individuals can go in there and be able to just click on the link and do the survey if possible. And if you have a question for any one of our panelists, to be able to just type it in the chat so we can be able to ask the question. So I'm going to introduce Pastor McCall again, who is going to be one of the individuals that will be bringing forth our questions. And then Mr. George Bode is another individual that will be speaking to the question too, and I too will be asking the questions to our panelists. So I'm going to ask Pastor McCall to unmute himself, starting with him if he has any questions.
Thank you, Lovo. Thanks to Dr. Abraham, and thanks to Dr. Sokolov for the very nice presentations. I do have two questions for each of our panelists. I'd like to start off with Dr. Abraham. Dr. Abraham, as a pastor and of course just working as a nurse, I also have very good concerns about guidelines for indoor activities. I know in your presentation, I'm not sure if it was very clear about specific guidelines, CDC guidelines for indoor activities. We do a lot of singing in churches, African-based churches. And of course, so we're out there and we're singing. But I recently visited a restaurant, and of course, they've tried to, as much as possible, social distance groups in restaurants. But I did realize that folks in the restaurants were grouped and they were unmasked. Now, how does that differ for those of us who are in churches and are singing? I mean, is there anything specific with regards to those two settings that you can talk to?
So two things. Recall when the original epidemic started a little over a year ago now, the first outbreak was in Washington in a nursing home. And then there was an outbreak actually in a church group. It was actually a church choir who had gotten together for choir practice. And 3 of the people were harboring COVID-19. And by the time their practice was over, 2 or 3 days later, the entire group got sick. So what did that tell us? So one thing that happens with singing as opposed to other activities is that there is more forceful expiration of air. And because of that, the virus can spread a larger distance. So it's a more efficient means of transmission. So how did we mitigate that? So in our own church, what we do is if they are family members, they can all sit together and we distance groups of families or single people apart. Everybody's masks. So any singing which happens is with their masks. The only time that they can unmask is when they're alone outside of the church building, but not inside the church itself. And so that activity would allow less transmission. What we also do is keep the windows open so that there is a cross ventilation of air, or you can have a HEPA filter or something else so as to circulate the air. There's a nice study from MIT published about 2 or 3 weeks ago, where they demonstrate that more than the distancing, the masking and the circulation of air is the safest way to keep a room safe. So both the CDC and the state of Massachusetts have issued guidelines as to how many people within what space how many people at a maximum can be at one place. So to address the question about restaurants, so good point that restaurants were a big vector of illness, which is why for a long period of time they had shut down in-person dining, because when you're sitting close together without a mask because they're eating, and more than 15 minutes or more than 45 minutes, there's high risk that you would acquire infection. So they waited sort of at a time when the numbers had come down, and in the interest of the economy and the businesses, et cetera, that restaurants opened and have opened now to capacity. So the only difference between a restaurant and a church setting is that when singing, there is a forceful expiration, so air travels longer. To mitigate that, if we continue to wear masks and keep windows open, which we can now with this weather, or use some form of air movement, either fans or HEPA filters, etc., then I think the church setting is equally safe as a restaurant. And in addition, if everyone is vaccinated, then the setting is even more safe.
Thank you, Dr. Abraham. So you just made your last statement, if everyone is vaccinated. Does that mean if we have proof of vaccinations, we can all be unmasked in churches? Is that what you're saying?
No, good question. Excellent point. So recall that vaccine is not 100% effective, right? Best case scenario, 94%, which means there's a 6% chance we'll still acquire infection even though we're fully vaccinated. So excellent point. We should be fully vaccinated as much as possible, everyone. But even if we are fully vaccinated, we should wear masks when in church, so that because we are in a closed setting where if there is not adequate movement of air, we are still likely to infect for the reasons I just mentioned earlier. So masking on top of the vaccination increases our chance of protection to almost 100%, never 100%, but much more than just vaccine alone.
Thank you, Dr. Abraham. So one last question on COVID before I move on to Dr. Sokolov. I realize Dr. Jala Kennedy, who is also an epidemiologist from Liberia, is on the Zoom call. So I'll pose the question to both you, Dr. Abraham, and Dr. Kennedy. Either of you can chime in. Is there any data on Liberia? Since in fact, this whole program is tailored to the African-American community, the African community, I realize that many on this program are Liberians. Is there any data on Liberia that you can throw out there that can help us educate our community, especially with Liberians, Americans traveling back and forth to Liberia and Worcester or the United States?
Maybe I'll ask Dr. Kennedy to speak first since I've spoken so much, so then I'll follow him.
Yeah, thank you. I've worked with the data in Liberia. I got stuck in Liberia when I went to do some volunteer rural work and stayed for some time and did some work with the Ministry of Health, WHO, the National Public Health Institute of Liberia, and CDC, the US CDC there. And I still continue to work with them. Yes, we have copious data. I actually have data up to date, including this morning or this afternoon. What it is in Liberia is that I would say it's unusual for how it is the data in Africa that I've been working with since March of last year overall, is that what we see going on is that, of course, the issue with people having all of the false information about COVID, and now we're struggling with a vaccine that is also going in Africa that people are refusing to take or are very hesitant. Is that they, at this point in Liberia, for example, you have about, and I would say this, about 98.5 to 99.2 almost % of all tests that are being done are done almost exclusively on travelers in and outgoing. So it makes it hard if you do any projection to understand that this is how the COVID cases are. And just between the day before, which was the 30th, we had 8 new cases. Of course, the testing is so skewed towards travelers that the citizens, and which I have been talking, and sometimes I'm on the radio or the television occasionally, talking that do not believe, because these people live in this population. And one good part is that the Ministry of Health, WHO, are doing very robust testing of travelers, so it's helping. For example, in the recent testing that happened of that you would say about 10 to 20 cases that will come, about somewhere around 65 to 75% of them, or even up to 90% will be travelers. So that's helping to reduce, and they also have identified a variance there, because most of the travels in there are from towards Europe. So it's causing those strains to be moving towards that direction. And of course, we have cases, they did see a variant that they attributed possibly, I could be mistaken, but from South Africa or somewhere. So this is the situation we have. The COVID numbers, when you look at the positivity overall based on the testing, which again is skewed, is not a very good statistical method to use. It is somewhere as low as 0.3 to 0.5%, which if it was in a normal projection, epidemiological projection, you would declare the country free. But because of all of these different numbers and the way they are not, they don't fit a regular model or the way you would look at, it's hard to make a judgment. So one thing that I work with them on a weekly or every 2 weeks is to make sure that I run for them the moving averages. And those moving averages I produce in such a way that it takes into account some of these issues. But again, on the bottom line for educational purposes, and thank you, Lobo, and all the team for doing this, is that we should continue to let our people in Liberia, in the neighborhood in Africa, to know that COVID is real and it's in Liberia, but we are not seeing it. And unfortunately, let me look at it the other way, that the citizens are not being affected, which is one good part of it.
Well stated. I couldn't have done it as well as Dr. Kennedy did. So the only other piece in this that I would add is that the other challenge that's happening is vaccine has not reached Africa yet, primarily partly due to cost. And the one place that vaccine was supposed to come from was India. India was supposed to ship because it's an inexpensive, the Oxford vaccine or the Astrozenica vaccine, but the India being so overrun with cases that they're not able to, only 1.3% of their population has been vaccinated. So vaccine has not been moving out. So the poorer countries who are looking for cheaper vaccine have not been able to get it yet. So that compounds the problem a bit. Fortunately, as Dr. Kennedy mentioned, since the cases are low, we're not seeing at least complications, but definitely would love to see a vaccine for all of them.
Thank you, Dr. Abraham, Dr. Kennedy, and Pastor McCall. So I have a question that was written in the chat for Dr. Sokolov. And this is, before I ask the question, Dr. Sokolov, I want people, individual, to raise their hands because we're having some issue with collecting the information from the chat. So if you can raise your hands for us to identify you, then you can ask your question if it's possible. But Dr. Sokolov, this question is for you, and it says, is the PSA blood test more accurate and advantageous than the rectal exam?
So it's a combination. It's a great question. It's one that has come up way back to even when I trained 20, 30 years ago. There are people who can have normal PSA blood tests and not have cancer. There are people who can have, and have cancer. People who can have the elevated numbers and not. Likewise with the exam, sometimes it's abnormal and people are fine. Sometimes it's normal and they're not. It's that combination, and it's also looking at trends. So single values of PSA, often we'll repeat them. We'll monitor men over short periods of time to see kind of if things are increasing, staying the same, if there's just something that's a little aberrant. But it's a whole combination of exam, blood tests, and then monitoring things over time as well.
Okay, thank you, Dr. Sokolov. So I'm gonna call on Representative Morris. Actually, he's one of the representatives from Liberia who is on the line today, so we appreciate it. And thank you again, Representative Morris. He has a question. I'm not sure who he's gonna refer the question to, but I'm gonna ask you to unmute yourself, Mr. Morris.
Okay, thank you, and greetings to everybody. Let me appreciate this all-important discussion. I'm from Liberia, and I serve in Parliament. However, there are so many skepticism that continues to linger in the minds of people as I listen to one of the panelists who talked about the traveling situation within Liberia and how the data is being collected. My question, and this stems from a lot of things that come up from people we interact with who are trying to encourage to take the vaccine, and most of them are concerned as to the differentiation between the different types of vaccine. Which one is more effective? Which one is less effective? And what are the efficacy rate between these vaccines? Because the Europeans are sticking to Astrozenica. The Americans are talking about the Pfizer. And so there is this confusion in the minds of most people, which of these can they actually take? So that is something that we need to actually, clarify or try to put at ease in the minds of those who are willing to take the vaccine, and whether the ones that are sent to Africa, they can trust those ones or only rely on the ones that the Americans are taking, or the ones from Europe. That's one. And the second thing is the gap between the first and the second dose. Now, in the States, there's a 3 weeks period. Now, in Liberia, there is a 1 month to 5 weeks period. Is there any effect to that? Thank you. And the question goes, anybody can answer that. Thank you.
Okay, excellent questions, both of them. And so let me try to address. So comparison. So there are two different types of vaccines, basic groups. So one is what's called the messenger RNA or mRNA vaccines, which is the Pfizer and Moderna. And then the other is the viral vector vaccine, which means that's the Johnson & Johnson and the Astrozeneca. They're designed similarly. The little particle from a fragment of the COVID-19, which is what the body uses to train itself to recognize coronavirus, is carried in by a vector. So an inactivated virus, that's why it's called a viral vector vaccine in the Johnson & Johnson, the AstraZeneca. And in the messenger RNA, it is covered by fat, what's called the lipid nanoparticle. And so when that enters into the cell, the little fragment is able to carry in. That fragment disappears in all situations, but the body develops the recognition mechanisms through a series of steps in immunity, which I won't elaborate on. But essentially, the body becomes trained to recognize SARS-CoV-2. And so when challenged with infection, the body quickly mounts a defense response. So that's the basis of the vaccine. So both the Pfizer and Moderna are completely equivalent in terms of both their efficiency as well as their ability to protect. The challenge with both Pfizer and Moderna is it needs a cold chain. So it needs to be stored at temperatures which are way below normal or normal refrigerator temperatures, because that fat molecule has to be kept intact. It gets destroyed at room temperature. The vaccine becomes inefficient. So one of the challenges that occurred is that this vaccine was useful in countries like the United States and Europe, who have the mechanism of being able to distribute the cold chain or maintain that cold chain while vaccine is distributed. It's expensive, it's cumbersome, and so that's why these vaccines were used most in the US and Europe, etc. So between the Johnson & Johnson and the AstraZeneca, the design is equivalent. However, I'll address the AstraZeneca in a moment and that'll also address the issue of how many weeks between vaccines. So for Pfizer and Moderna, it's either 3 weeks for Pfizer or 4 weeks for Moderna between two doses. They generally give about a 2-week additional period. So about 6 weeks or so, you can delay before you get your second dose. And both doses are essential to develop the full immunity. There is several good studies which demonstrate that people who've had significant COVID-19 as an illness may benefit with just 1 dose of vaccine. They don't need a second dose. However, that is still being completely confirmed, and that's why the recommendation still is everyone should get the vaccine, both doses, if they're getting a 2-dose vaccine. The other piece is, the question is, when can they get the vaccine? And the short answer is, even if they've had COVID, as long as they have no symptoms, they can safely get the vaccine at any point in time. There is no waiting period for the vaccine. So Johnson & Johnson, slightly different. When Johnson & Johnson was studied, it was studied later compared to the Pfizer and Moderna. So Pfizer and Moderna was studied between July and September to October of 2020. And the results were out and the vaccine was available by December of 2020. Johnson & Johnson was studied between October and December of 2020, and the vaccine became available only in January, late January, early February of 2021. So what's the difference? The difference is when Johnson & Johnson was studied, there was more variants, and so Johnson & Johnson vaccine was studied against both the variants and the original virus. Pfizer and Moderna were only studied against the original virus, And so they did a follow-up studies in the people who had variants to look at its effectiveness. So in the United States, Johnson & Johnson had an effectiveness of 72%, while Pfizer and Moderna, when they studied it using both variants and the original disease, from the original 95%, it dropped about 20%. So they came to about 75%. So what does that mean? The percentages are numbers. The bottom line is all three vaccines are equally effective. They protect completely as best as is currently available against both variants and natural disease. And so there is no reason to pick and choose between them. Any one of them work equally well. Whatever is available, take it. The advantage of Johnson & Johnson is only a single dose required as opposed to the others require 2 doses. So Johnson & Johnson is ideally designed for developing countries, large populations, etc., because it is more difficult to go back and identify people who got the first dose at the right time to give them the second dose. The 1-dose vaccine is very attractive from that standpoint. Now, what happened with AstraZeneca? So AstraZeneca is also called the Oxford vaccine. The technology was developed in the University of Oxford, and it is actually manufactured in India. So 100 million doses are manufactured in India of that vaccine by the Serum Institutes of India, which is a manufacturing company that manufactures vaccine for both India as well as for several other developing countries. The vaccine is cheaper. It's a 2-dose vaccine, and it is stored at room temperature. So lots of other things are easy, but it's a 2-dose vaccine. What happened with AstraZeneca and why is it not approved in the US as yet? When AstraZeneca developed their vaccine in their studies, they ran into a little glitch. A portion of the people who were studied got only half the dose for the first dose of the vaccine, and they got the full dose for the second dose of the vaccine given 4 weeks after the first dose. So they called it low dose, standard dose, as opposed to standard dose, standard dose. When they did an analysis of the results, the people who got the standard dose, the full dose of the vaccine with the first dose and the second dose, had only a 67% response rate, and the people who got the low dose and the standard dose had almost a 90% response rate. So that really threw off the researchers because they said what went wrong, that people who got half the dose first versus the full dose seemed to do better than the full dose. So which means it defies all logic. So in order to be able to replicate that when they were rolling the vaccine out in the UK, because it's their vaccine, they needed to use that. That's why Europe used so much of AstraZeneca. So what happened was to replicate that, what they did was they stretched the interval from 4 weeks to 12 weeks. So they did their second dose 90 days after the first dose to try to make the effect of the first dose like a half-dose vaccine so as to maximize their benefit. So that is the problem. So when AstraZeneca applied here in the United States, they've had some problem. Their efficacy, at least quoted here, when calculated is about 82% at their standard dosing intervals. But because they've yet to file, they filed all their paperwork with the CDC and the FDA, and they're sort of dragging their feet a bit because the US frankly has 3 other good vaccines. So it's in no hurry. We will have achieved full immunization because we have enough vaccine. We have actually more than enough vaccine for all the people in the US today without having to use the AstraZeneca vaccine, which is why the US has shelved its AstraZeneca vaccine, and there's pressure now on the government to release it to countries who are hurting and need vaccine because they are willing to take the AstraZeneca vaccine, as India is and many other countries are. But here we have a choice of 3 excellent vaccines. So the bottom line to the response is all 3 vaccines are equally good. Either one of them, whatever we get, we should take. For developing countries, the Johnson & Johnson is the most attractive because it's a single-dose vaccine. AstraZeneca has some problems in terms of, that's why the interval was increased. So it has varied from country to country. So in India, for example, it's 2 months instead of 3 months. In the UK, it's 3 months. But the original dosing interval was stretched so as to be able to accomplish the effect that I talked about earlier. I hope that answers the question.
Thank you, Dr. Ibrahim. Before we move on, we have reached, yeah, our time, but we will appreciate moving on if that's okay with everyone. If there are still questions to be asked, and you, Dr. Abraham, Dr. Sokolov, Dr. Fina, if you still want to proceed just to give some clarity to the people, we can move on because we have a lot of questions. I just didn't want to shut everybody off or just, you know, overlook the questions that are being asked. So if it's okay, we can move on. Is that okay?
Fine with me.
Okay, so before we move on to the next person, I'm going to ask just everyone, if you are being asked to speak, just make sure you're not in an environment where the noise is too much. And to also remind everyone that the survey is still ongoing, so just please remember to take a minute and just be able to do the survey. It's less than a minute, real quick. Just do it before we go on. So if everyone can just take that a minute. And where it says ethnicity, we want people to write whether you're Liberian, you're Ghanaian, and all that stuff, because we just want to be able to make sure we get a true data from this survey. Thank you so much. And my question is going to go to Dr. Sokolov. This is a personal question of mine, and I just want to know if somebody already has prostate cancer and they're undergoing radiology, is it okay for them to take the vaccine? How does that work? How does it affect one another? Radiology, someone undergoing radiology and going to take the vaccine. Is there any research on that, or can they take the vaccine?
That's a good question, Lovo. And I've had a lot of patients ask me that with regard to surgery, because they're scheduled for surgery with me, and then they want to get the vaccine, which is incredibly noble. And I've usually been telling them try to, make the first shot about 2 weeks in advance, so that there's a good week or two after surgery in between everything. But that's just anecdotal. I mean, I have no real good data on that. I have very little on radiation also. I mean, one could imagine maybe some effects on the immune system, but to be honest with you, I personally wouldn't be concerned. I have no data to say that, but I might actually ask Dr. Abraham for his thoughts on that one. I would think it's safe, but I don't know if there is any data on that. Dr. Abraham, I'm sorry to throw you under the bus here, but
I agree with you 100%. You're absolutely correct. So I would also consider exactly. I agree with Dr. Sokolov completely.
Yeah, I would think it's safe.
Oh, okay. Okay, that's nice to know. So, okay, so Dr. Sokolov, Rufina, get off.
Yeah.
So there's the question of infidelity.
Infidelity, okay.
Can you please speak to that?
I think it is infertility, Dr. Sokolov.
Oh, infertility. Oh, infertility. Thank you. I was going to say, I've done this for a long time, and infidelity I've never really hit with. So, I mean, if we're going to talk about it in the context of prostate cancer, even with prostate cancer, men can be fertile. There's no real transmission from man to woman, and that's all safe, and there's really no issues there. And prostate cancer by itself does not cause infertility. Now, if one does have treatment, so if one has surgery or one has radiation, that effectively shuts down the reproductive tract. So natural approaches to reproduction are not going to happen. The sperm aren't going to get out of the body the normal way. The testes should be totally fine. The testes should be normal. And one can always have artificial insemination and use some of the infertility techniques that we all know of. So with treatment, you'd probably go sort of an artificial route. Without treatment, no issues whatsoever. And that's kind of, I guess, the story on the infertility side.
Okay, so if you have any question, we'll appreciate it if you raise your hands.
The question I have is relating to the second dose. Why is it heavier, or more people complain about the second dose with, aches than the first one?
I think the simple-minded way of looking at it is the body is just being trained to become more immune or recognize the virus. So that's just your normal immunity reacting. In general, if we were to compare ages, the older the person, the less the reaction. The younger folks, there's a little more. But that is all the components in the vaccine other than the actual vaccine itself, which induces the immune response. So it lasts for 12 hours or so and it goes away. A little Tylenol or anything like a Benadryl or a Claritin is something which will help reduce the extent of those side effects, but they're minimal in general and not long lasting.
Okay, and a follow-up to that, that has to do with traveling. In most countries, when you arrive, you have to be tested. When you depart, you have to be tested. Now that the restrictions are being put into place with the 6 feet to 3 feet and being on masks when you're in certain places, but maintaining a certain distance between you and the other person, what is it that the CDC or the administration, as respect the vaccine that is being given to people, what is it that is being done with airlines and airports or other countries, governments, to make sure that one who have taken the both doses are exempted from the various tests at the port of entries?
Yeah, so good question. Like we talked about earlier, the vaccine is not 100%. So people who've had both doses of vaccine, we know that they are much less infectious. They're much less ready, will transmit infection, but it's not zero. So the testing as yet is not been removed. Whether it'll happen in the future is questionable. At this point in time, you would still be tested both at the entry into the country where you're traveling to, and on your return into the United States, you need to show a negative test when you enter and repeat a test here within 72 hours of your arrival and demonstrate that to be negative as well. And the reason is that there is that small fraction of people who can still transmit infection. In the future, will that change? Potentially likely. There is a lot of arguments about having what's called the COVID passport, as it's called, where somebody shows proof of having received both doses of vaccines. Why are there controversy around it? Number one, it sets up a degree of disparity. So for example, in the African community, as we saw in Dr. Castile's slides, or the Latinx community, etc., have not gotten as much vaccine. So people who have not had the opportunity to get as much vaccine are disadvantaged if we were to create that sort of disparity by having a COVID passport. Number two, there are fake passports. So there are these CDC cards that people buy off the internet for a price, basically write in their name and put in a date and then demonstrate that, oh, they've gotten it when they really don't have it. That's one of the reasons, the latter reason, why countries still require you to test, because there is no picture or there is no other electronic mechanism to independently verify that the person who claims they've received vaccine actually has. So that's the challenge as of now. Things may change in the future once there's been more vaccine available and received by people all over the world, not only here in the US.
Okay, thank you. One last thing. The first dose, when taken, I believe introduces the body to whatever that the second dose or the body should be able to react. Now, upon taking the second dose and you are to get tested for COVID before travels, will it not show that you are positive even though you've taken the 2 doses?
Not at all. So the test that is done, which is the nasal swab, the swab in the nose, tests for the presence of virus, does not test for the presence of immunity. What the vaccine gives you is immunity in the body, doesn't introduce virus into the body. And so you will never test positive on a nasal swab if you've gotten the vaccine, whether 1 dose or 2 doses. So the 2 are mutually exclusive.
Thank you. Thank you, Doctor. Thank you so much.
Okay, moving on. I just want to re-emphasize that we are hoping that everyone would truly go into the chat and be able to do the survey. Please. We need the data, and as of yet, we have, I think, 18 individuals, and this is out of some 40 people that were on, so please. And secondly, thank you. And secondly, we're hoping to just do a quick screenshot. If everyone can just please turn their camera on just for a second? Please. Can you see it? Are you ready? We're gonna just take a quick screenshot.
Everybody smile.
Smile.
Yep, I'm taking it. I'm taking multiple. Okay.
Okay. Okay, thank you, everyone. So I'm gonna go over to Grace. If you can just please unmute yourself. Everybody can turn their camera off. Unmute yourself, Grace, and ask your question, please. Thank you.
All right. First of all, I would like to say thank you so much, Lovo, for the awesome work that you're doing in Worcester. I used to be in Worcester and knew Lovo when we were there, and we've kept in touch. I now live in Florida, but currently I'm in California on a work assignment. I did my first COVID shot in Florida, the Pfizer one. And then I was supposed to get the second one within 2 weeks, but then I came for this assignment about almost 4 weeks ago. And so in total, it's been almost about 6 weeks since I had the first one. And there's no Pfizer vaccine where I am. Yeah, so I tried to do the Moderna, but then they said that they can't mix vaccines. So my question is, what do I do now? I'm not able to get access for, get the second dose of the Pfizer, but then I'm not able to also get any other vaccination. I'm not sure who would be able to answer that.
So I'll respond briefly. Good question. This is a dilemma. So there is studies ongoing right now which are looking at the interchangeability of vaccines. So at least between Pfizer and Moderna, there's so they can't be interchanged with the Johnson & Johnson or AstraZeneca, but at least interchangeability. And the general feeling is it might be interchangeable. However, we don't have official permission. The data is not there. So as of this point in time, it's still premature. That's why nobody will give you a different manufacturer's vaccine as yet to be able to allow that interchange. So unfortunately, at this time, the best answer is still searching for any place that you can travel to get your second dose, including coming back to Massachusetts if that's an option, because the large vaccination sites in Florida should be able to have some Pfizer. They can't be exclusively Moderna all over the state. I think it may need some searching. Unfortunately, there may be no other option.
Okay, thank you, Grace. Thank you, Dr. Abraham. We're gonna go over to Lori. Lori, are you there? If you can unmute yourself and ask your question, please.
Hi, I'm unmuted, but I don't have the video. But my question is for Dr. Sokolov. If somebody is diagnosed with prostate cancer and it spreads to the stomach, what is the prognosis for that?
That would be incredibly rare. Different kinds of cancers have fairly specific patterns of spread. Prostate tends to go to bones, like the hip bones, the pelvic bones, ribs, and usually to lymph nodes, which are organs throughout the body. Extraordinarily rare that they would end up in other organs, especially the stomach. And I would want to make sure that that was truly biopsied and evaluated to make sure that was truly a metastasis to the stomach. I would think the prognosis would be like any other lymph node metastasis, in which case, you know, there are drugs that can keep things in check for many years. But I've never heard of spread to the stomach ever. Even liver is pretty rare. I've only seen that once or twice in my entire career. So I'd get tissue to make sure it's prostate cancer, but I would imagine the treatment would be the same if it was in any other kind of what we call soft tissue.
Okay, and I just have another quick question, because a friend of mine who actually had it done at UMass, they said that it was in the stomach and they couldn't tell if it was in the hip. They were gonna re-image him or something to check, but should he get a second opinion?
I mean, it always feels good to have a second opinion. I can tell you that between our surgical staff, our radiation oncology staff, and our medical oncology staff, it's about as good as it gets, including with imaging and with pathology. I mean, We've got real leaders, national leaders in all of those throughout the institution. Sometimes it feels better. You know, obviously we're right down the street from Dana-Farber, so it's very easy to get an appointment and a second opinion at a leading cancer center. And if that makes someone feel better, absolutely. And again, stomach just seems a little bit odd.
Okay, great. Thank you so much.
Certainly.
Thank you, Lori. And my question before we move on to Pastor McCall would be to Dr. Fina or Dr. Sokolov. And for people that have been diagnosed with prostate cancer, what are the resources out there? Since I know you both have worked with individuals for so long, what are the resources out there for people who can afford it when it comes to radiation therapy and moving forward with their plan of care?
Mitch, do you want to address this question? Yeah.
Yeah, I'm glad to, Dr. Stern. I mean, there are traditional resources in the community, treatments. I mean, and we're very fortunate in Boston to be around a lot of very strong academic institutions in Massachusetts. I should say Boston because we have to include Worcester within there. So in terms of getting advice, getting state-of-the-art treatment, that's readily available anywhere. If people just feel uncomfortable and want information, obviously within the internet, one can query organizations like AdMeTech, Prostate Cancer Foundation, American Cancer Society, American Urologic Association, and one can get information there. Fortunately, all of the treatments that we do are all covered by Mass Health on up to private insurance. So I'm not sure there's a financial resource question or if this is just a literature resource or just making sure they're getting good care. But I would say that in Massachusetts, we're fortunate. All of the major institutions have excellent programs. There's plenty of available advice online from very reputable sources, and all of it should be covered by all of the traditional Mass Health on up. Faina, any thoughts you might have?
Absolutely. Once again, AdMeTech Foundation is dealing with education and information. Obviously, University of Massachusetts is an outstanding resource for anyone in Worcester County. For people outside of Worcester County, please call AdMeTech Foundation 617-523-3535 if you feel you have a need for further education. If you have any questions about clinical resources statewide beyond Worcester, we'll be happy to work with you and make sure that you will get all the answers you need, and you will be connected with physicians who are the best in the field.
Okay, thank you. We are still wanting more people to go and do the survey. There is a link in the chat. If you just hit the chat icon, there's a link, just hit on the link and it's gonna take you right into the survey. And Pastor McCall, if you will unmute yourself.
There's a quick question for Dr. Stern or Dr. Sokolov. Thanks for answering the question with regards to cost and coverage by insurance carriers and our hospitals in the Worcester area as well. That eases a lot of the anxiety that sometimes people within the immigrant population has, especially if you have someone who's new to the area and perhaps is in the process of applying to Mass Health. There is always this concern about cost. I know Dr. Sokolov spoke about the PSA blood test, the finger stick versus the digital rectal exams. But in just a follow-up, I'm not sure if I missed this part from either Dr. Stern or Dr. Sokolov. Could you talk about the age of screening for us, please, for prostate cancer?
Of course, it's the best guidelines we have in this country are coming from National Comprehensive Cancer Network, consisting of 29 top cancer hospitals in the country. And their recommendation for people who are at average risk of prostate cancer to start, essentially no additional risk of prostate cancer, to start screening at the age of 45. However, for people with higher risk, at higher risk, such as men with African heritage, any Black men, men with history of prostate cancer in the family, particularly father and or brother, men 50 and above, to actually, before men with family history and men with essentially African heritage, to start screening at the age of 40. So because right now there is, over the last 10 years, that has been shift in the way people screen appropriately. So early, what we call baseline screening at the early age becomes very important to map out next steps in prostate cancer screening, how frequently it will be, at what age it will be repeated, et cetera, et cetera. So for men at high risk, African heritage, family history, starting at 40. For men at average risk, starting at age 45.
I would agree with that, and Dr. Stern is absolutely correct in terms of the frequency. There's some good studies that at age 50, if you have a normal blood test, you can go several years without another one. But those are all things that haven't been brought into the screening paradigms. But the 40 and 50 age ones are the simplest to remember.
Oh, thank you. So, Dr. Sokolov, when it comes to screening, because I've come to understand that most often individuals will not ask about the test. So what is the process if someone have reached to the age and they are at their doctor's office for a doctor visit? Do you explain it to them that we're going to do this, or is it when they're asking a question to have the test done, or you just right on just go and have the test done?
So I'm usually sort of the second step in that, because by the time many people get to me, they've been referred by their regular internist or primary care doc. Although I do see people who call out of the blue saying, I want screening, and you discuss it with them. But the word to get out is ask your doctor to get a PSA blood test. You know, in this population that we're talking with, and you're 40 years old, ask them. And if they say no, then get a new doctor. But I mean, it's unfortunately, it does take a little bit of one's own self-motivation and self-drive, but ask for it and you'll get it. Again, by the time I'm seeing people, it's usually one step further down the road.
I think that if anyone will take one take-home point about prostate cancer from this event, is that, as Dr. Sokolov pointed out, everything starts with screening. Screening is the best way. Screening with PSA blood test, it is the best way, the best tool we have to detect prostate cancer early when it is curable. And it is critical for men, particularly men with African heritage, who are at much higher risk to have life-threatening prostate cancer. It's really critical to be an advocate for yourself. Which means if your physician does not offer you a test, please discuss with your physician if PSA blood test screening for prostate cancer is the right test for you.
Thank you, Dr. Tina. So let's see. I'm just gonna see if there's any other question in the chat, but we're still asking people to do the survey. And I know we are way past the time, and if people still have questions and they want to move on, and if that's okay with you, Dr. Abraham and Dr. Sokolov.
Actually, I'm gonna have to log off. I have another meeting I need to be on, but I want to thank you and Dr. Stern for inviting me, and it was a pleasure being with Dr. Abraham and some of the other speakers. Just keep up the great work, but I'm gonna have to log off.
Thank you, Dr. Sokolov.
Sure. Bye-bye.
Bye. And so, well, there is not any more question in the chat. I just also will like to say thank you to every one of you who took off your time to be here. Dr. Abraham, we're very appreciative of your presence. And from AdMeTech, I don't know, what can I say? We just appreciate the administration. You, Dr. Fina, you've been like from the entire week, been focusing on making sure that everything goes well. And we really appreciate all the support from AdMeTech and bringing this into our community where there is actually a need. We really do appreciate it and appreciate you coming on. So we just want to encourage everyone that with this present pandemic, Chen has also been working with the city of Worcester, and beginning tomorrow, we are starting the Get Vaccinated Worcester campaign, and that is in collaboration with the city of Worcester, the Health Foundation, and the Mayor Foundation. So these three organizations have come together to encourage grassroots organizations to really come forward with the campaign on people getting vaccinated in the community. So I just wanted to say that if you are a religious leader and you will want your church to participate in this vaccination campaign, you can reach out to me through Chin, or you can send me a text or call me so we can just get the process going. But I just wanted to throw that out there. I also wanted to encourage everybody that this vaccination is not just for you as a person, it's for you, your family, your friends. So you are standing in a gap, and just imagine those that never had the opportunity to make the choice whether or not to take the vaccine. Those that lost their life to this and they never had the chance. So once you're taking the vaccine, you're taking the vaccine, I believe, for people who are in your circle. So just a food for thought for people that are trying to make the decision. And this was very informative, and that's the purpose of it, to inform everyone on here and to help all of you make an informed decision whether to take the vaccine or not. So thank you so much to Rufina, who has been very great. She's our intern and she stood the test. To Mr. Boley, Pastor McCall, who came in and took the stand for us, Dr. Abraham, and all our visitors in Worcester, in and around the world. We want to say thank you so much to everyone. AdMeTech, our hats off to you. Thank you. Thank you.
Thank you very much for your work, Lova, Rufina. Thank you so much for your work with Chen. And thank you very much to everyone who participated in this event.
Once again, we want to say thank you to everyone. Dr. Fina, Dr. Stern, we did such a great job like trying to coordinate this. It was tough, but I'm glad that everything came together. When we're talking about the surveys, we actually had two different surveys. We had the participant questionnaire, and right now we're trying to get data. Within the African immigrant community, usually we are categorized as Black or African American, and we want to have this data in order to help us achieve health equity for specifically the African immigrant community. So it's so important that you guys go ahead and take this survey. Also, there's another survey that's going to be placed in the link, which is a quality improvement survey. Hopefully after this, we will have more Zoom events, virtual events, where we'll have discussions on other health topics. So we want to know, we want to get your input and feedback on like how you guys felt about this event, what we could do to make it better. There's a lot that we want to do in the community, and we thank you guys for coming out to support, even though, you know, it's virtual and, you know, because of COVID restrictions and guidelines, but we just want to keep this going, the awareness campaign. So you guys, I'm gonna, once again, put it in the chat. If you don't know how to use the chat, because I know some people are not tech savvy, it's at the bottom of your screen. You click it, and then you will see everything. I'll put the two different links. So one is the quality improvement survey, and the last one is the participant questionnaire. So once again, we say thank you guys for coming on, and we appreciate everything. Thank you.
All of you who are still on, we want to still say thank you, thank you, thank you, and just remember to do the survey before you leave. I'm still going to be on here.